sorry about that.
All right. Good morning, everybody. And I guess we should start since it's the Friday before Memorial Day and thanking everyone who served. Appreciate the sacrifice that you made. And I hope everybody has a great Memorial Day weekend. And what better way to start your Memorial Day weekend than talking about the Episode Quality Improvement Program? So it's like the party has already started. I'm going to get right into the content, and I'm Gene Ransom from MedCai, and I'm going to turn it over to Jessica from CRISP to jump right in to the amazing updates we have this morning. Good morning, Jessica.
Good morning, everyone. And yes, we don't have a packed agenda, but some, I think, very interesting and important updates. We will start with talking about grants. So we do have some follow-up about the practice transformation grant, which we introduced last month, but we also have Melanie from MHCC to talk about another grant and the opportunities that that presents as well. So Melanie, you want to talk first, then we'll jump into the rest of our slides.
Great. Thank you so much, Jessica. So many of you know me. I'm Melanie Cavalier, the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. So as I've mentioned on some prior calls, MHCC does have a practice transformation grant. We're very excited. We're getting ready to graduate our second cohort of practices. And what we have found is that over 50% of the people who go through this program are now participating in value-based care programs. So we really think that we're helping these practices who may not have made a jump like that on their own to be able to successfully now be part of the value-based care landscape here in Maryland. So it's open to any practices that are not in MDPCP. So you can reach out to me and Jean. And the program consists of trainings, workflow redesigns, and assessments, which we start off with to help them kind of understand where they are and what milestones they should go through. And it is based on the Transforming Clinical Practice Initiative materials that were part of the Practice Transformation Network. And that included over 100,000 practices nationwide. So it was also designed by them to support their MIPS program. So if anyone has questions or wants any additional information, happy to answer them. Thank you for giving me some time this morning.
Thanks, Melanie.
And
so
just to put a little color on things, we've actually helped practices that literally were on paper. I mean, we will take anybody. So if they are at level 0, that we're willing to start from wherever they are and try to get them into some kind of program that makes sense. So for those of you who know those smaller practices who really are not ready for this is the perfect program to get them into value-based care. So just would encourage people to sign up as soon as possible if they're interested.
Thank you all. So we will then, I'll hand it over to Kim, who's our lead on the practice transformation grant. And we wanted to bring back some of the conversation and follow-up that we talked about last month. So Kim, if you want to jump on in.
Yeah, thanks, Jessica. Good morning, everybody. We just have a couple of updates we want to bring to your attention regarding the practice transformation grant for EQIP. First and foremost, the eligibility basic requirements are that the entities are committed to the upcoming performance year. That's first and foremost. The other item is that we are accepting applications from program year 1 through 3 entities that did not have realized shared savings. So program year 1 and 2, they will have at least 1 year of savings, and then the new program year 3 practices, obviously at the time of the application, we're not going to have enough information to discern whether or not the practices will have any savings. So we're asking that we're allowing you all to apply as well. If you take a look at the screenshot that you see over on, I guess, the right-hand side of your screen, you'll see in the portal, this is where the very last button at the bottom, that's where you're going to apply for the practice transformation grant. Then once you apply, again, it'll be through the portal, and it's going to mirror the application period. So it'll start in July and end in August. And you apply the same way. I mean, for the practice transformation grant, you're going to apply at the same time as you're applying for the new year. Your evaluation process, so the practices will submit their application through the portal. Then there will be an application evaluation just to sort of make sure that everybody meets the standard requirements. And then from there, there'll be a practice assessment, which will kind of include just overview of how your practice runs, your workflows, and your specific needs. Next slide. And just to give you guys a quick glance at a proposed timeline. So again, the application process opens up in July, will end in August. Then in very early September, the application evaluations will be done. And then from September through October is when we're looking to have the practice assessments done. And that's give or take the amount of practices that we have applying. But this is about the timeline that we're expecting. And then in November, you'll be notified as to whether or not you will actually receive the grant. And then in January, obviously, the grant begins. Next slide. Just wanted to also remind you all of what the Practice Transformation Grant offers. So data analysis, where we help you or provide someone to help you pull your data, and whether it be from the EE portal or, as you see below, from the EHR to provide actionable items. Thank you. And then EHR optimization, where we help you optimize your EHR, whether that be with standardized templates, any kind of software updates, making sure that you're plugged into all the necessary things that you need to be plugged into. Next slide. HCC performance. So this could be chart audits. This could also be making sure that you are coding appropriately, that you're actually receiving your accurate reimbursements. It will help you improve your KPIs, your quality metrics, and also improve your clinical documentation. Care management or care coordination is pretty self-explanatory, making sure you have some sort of process in place to manage your patients in their care with their chronic care management and otherwise. And then any other transformation / performance improvement. So just ensuring efficiency of operations, ensuring that leadership is committed, your staff is committed, making sure that you have good strategies for your quality improvement. That's it. That's the updates. I'll pass it back to you, Jessica.
Thank you, Kim.
Can I ask a quick question? So
Absolutely.
I saw the application, Kim, was on the practice level. Can the entity level also apply, or is it really practice level?
It's actually the application at the entity level. So think of it when you're enrolling in EQIP, so you're enrolling at the entity, you would apply at the entity level too.
Okay.
Knowing that there may be multiple practices within that. And that's a little bit of why there's those couple other steps as far as evaluation and assessment,
Correct.
because it's not going to be necessarily the exact same situation for every entity that applies.
Right. And that's helpful. And I guess when you do the application, there'll be some discussion about what the needs are, because some of the every entity is different, right? So
correct.
One entity might say, I have these 5 practices that need this level of help, and I have these 2 that have this level, and the grant is flexible enough to work through that.
Yeah, and
That's
so that information will be in the initial application, and then we'll get further detail when we do the practice assessment, because obviously only so much can be captured in just a couple, free text and checkboxes and stuff like that.
And then I just want to also clarify for everybody. So we are talking about 2 different grant opportunities for 2 different situations. So the grant that Melanie talked about is the Maryland Healthcare Commission grant, which is for people who are not in value-based care and need to get into value-based care. This grant is for people who are in EQIP and meet certain conditions where they need additional help. So that maybe we should think about how we name them so people know what they are, because they do 2 different very important things.
Well, we can name this one the EQIP Practice Transformation Grant.
Yeah, and I think Melanie's grant is a great on-ramp, obviously, to this program, and even potentially needing additional assistance once you're in a value-based program. So, okay, well, great. Thank you, Kim. We're going to move on to our next topic item, which is some follow-up about the PY4 Episode Grouper. There is some updates as far as enrollment policy. That's really the main feedback that we're giving here. I'll ask you guys to be patient as we explain it, and then we'll give an example of it, and I'm sure there'll be some conversations and questions about that. But just as a reminder, we are entering our last month before enrollment period opens. So really, again, kind of fine tuning everything when it comes to definition, especially this large transition that we're doing with the groupers. So for when it comes to PACEs, which is obviously the new grouper we have been using, we're at the point where only 2 customized episodes are going to be utilized, which is the colonoscopy and upper GI, endoscopy episodes, and really that just has customized lengths in that to mirror that we're used to in Prometheus. And then we have 4 net new episodes in PACEs that have been added. So rheumatoid arthritis, rotator cuff, and the 2 behavioral health episodes, recurrent depression and chronic anxiety disorder, which will be options for enrollment for this upcoming PY4 year. Okay, so let's talk about the enrollment policy. So as we know in the analysis we've done previously, there's a really high level of alignment between PACEs and Prometheus when it comes to the cost that's captured, the overall trend in savings and dis-savings. There's some great alignment there. But there's some pretty material differences, and that mainly comes to fruition when it gets to the granularity of the PACEs episodes versus Prometheus. And this is as to be expected when we're going from under 100 episodes in Prometheus to now about 1,000 plus episodes in the PACEs option. So knowing that some of that level of detail can impact eligibility, it can impact some of the enrollment decisions that are going on, the HSCRC wanted to put forward a policy that essentially eases this transition of all of our existing participants and mirrors essentially, or tries to mirror as close as possible to the level and the type of participation that they have been used to over the past 3 years. We'll have to say that this primarily, we see the largest differences in this when it is having to do with acute episodes. There's kind of more closer alignment or easier alignment with some of our procedure-based episodes and things like that. So what are we doing for that? Essentially, we're creating what's going to be referred to as enrollment groups. And what that means is all PACEs episodes will be mapped to a singular enrollment group that most closely represents the existing EQIP or the existing Prometheus episodes or bundles that you all are used to. Note this can be a 1-to-1 ratio, this can be a 1-to-many. Again, it's going to sort of depend on the granularity and the differences in granularity between Prometheus and PACEs. And again, we'll walk through an example of what that means. When you are enrolling or electing to participate in an enrollment group, that entity is automatically enrolled in all of the mapped PACEs episodes under that enrollment group. So if you think about it, if there's 2 different PACEs episodes mapped under an enrollment group, an entity goes in and selects that enrollment group, they are selecting to participate in both of those PACEs episodes. Now, we're also going to introduce some terminology of a parent and child episode. So within PACEs, they have some relationships between different episodes, parent and child episode, or the condition episode, which is the parent, and the treatment episode, which is the child. And because of this different level of granularity, we actually have another option or decision that entities can make when it comes to enrollment. So if an entity wants to enroll directly into a treatment episode or child episode, so think of it right now, it's nested underneath a parent episode, nested underneath an enrollment group, but an entity really just wants to enroll in that one treatment episode, that is actually an option that they can have, but an enrollment choice must be made. If they'd like to do this, an entity can either choose to enroll in the condition or parent episode category in which that treatment/child episode lives under. And again, they'd be enrolling in all of the other included episodes within that enrollment group, or they can choose to enroll in just the treatment episode directly. That treatment episode would include all of the volume of that treatment episode, regardless of their parent episode association. But now that entity would not be eligible to enroll in any enrollment group that would include that child episode. I'll walk through what that looks like because I think that was a lot of words and a lot of terminology. So this is an example. Please take these numbers, they're not really accurate numbers, but it's just essentially a model. So let's walk through those bullet points. So the first one we talked about is creating this idea of an enrollment group and that there can be a one-to-one or one-to-many. So if we look at this table right here, an example of one-to-one is our knee arthroscopy enrollment group, which is only inclusive of one PACES episode, knee arthroscopy, pretty straightforward. But we can have enrollment groups, which is a one-to-many. So the enrollment group here that's labeled colonoscopy actually has 3 different PACES episodes as part of it. You can see the 3 that are listed here. When an entity chooses to participate in colonoscopy, they are choosing to participate in all of the PACES episodes that are mapped underneath of that. So all 3 episodes that you see here. I do want to note that their eligibility is at that enrollment group level. So we are summing the contributing volume of the PACES episodes, and that is what is the contributing, or sorry, that is the eligibility volume that goes in here. And that is some of the intent of this policy was solving the issue that when we got too granular with PACES episodes, it really diluted volume and things like that. But we are not seeing that problem as we have created or are creating these enrollment groups. So that's the enrollment group idea. Now let's get into these parent and child condition and treatment episodes that we just introduced. So AMI, if we look at this example, the AMI enrollment group includes 2 different PACES episode categories. Parent categories, and then underneath those PACES episodes, there's actually treatment episodes or child episodes. So again, we'll walk through this. The AMI enrollment group has an AMI PACES category, and that AMI PACES episode category has 5 different child episodes. And we're going to look at PCI as an example. So an entity, if they're enrolling in the enrollment group of AMI, they would choose to be enrolling in all of those parent and child episodes that you're seeing listed here in this table. Now, an entity could say, but I actually just want to enroll in PCI. That is an option, and essentially we can pull that out, and there's a PCI treatment enrollment level that they can elect to participate in. Now, this is an or option. An entity could not participate in the AMI enrollment group and the PCI treatment group because of the duplication that it would create there. Now note, this PCI number that's nested as a child episode, so this 56 volume, is only PCI child episodes that were created as part of a parent or the AMI episode. So it would be expected that when you're looking at the treatment episode or child episode independent, you likely will see a higher volume. So this 80, again, these are model numbers, but this 80 number would be inclusive of the 56 PCI episodes that are in the AMI category and any other PCI treatment episodes that were created outside of that parent episode. So I think that was a lot. So again, to kind of re-emphasize the decision that you all have, if an entity was looking at this and they were a cardiology and GI multi-specialty group, they could choose to enroll in the colonoscopy and AMI enrollment group. And you can see the volume would be the sum of these 2, the 474 and the 178 number. Or they could choose to do colonoscopy and the PCI treatment episode, whereas the volume would be the sum of 474 plus the 80. They would not be able to do both AMI and PCI treatment. So it could be a little bit of a decision as far as essentially where your all's intervention is, if there's some subspecialty associated within your group. But essentially, this is going to solve the eligibility issues that we were worried about when moving to such granular and specific episodes. I'm going to pause here in case there's questions. Actually surprised I'm not
So quick
seeing
question. This is Dr. Baheti. I'm primary care. So how does this sort of play in our setting?
In the primary care setting?
Correct.
So I think a lot of it is dependent. One of the big follow-up pieces that I'm sure y'all are asking was, okay, well, what actually are these enrollment groups, and how many child episodes may be impacted? So I think to answer that specific question, we probably would wait for the transition guide and we can actually kind of figure it out. As we mentioned, we feel like most of the time the acute type of episodes are the ones that are impacted by this. Some of the other like chronic ones are a little bit more straightforward. So unfortunately, I don't have a direct answer for that. It's a little bit is dependent on which episodes you're participating in, and the ultimate grouping of all of the PACES episodes to the enrollment group. But we will, and I think on the next slide, one of the big things that we're committed to is this transition guide to help everyone as they're looking at, here are my existing Prometheus episodes and bundles. What does that relate to when it comes to the enrollment groups that are an option, and the decision of the potential treatment or child episodes that I can decide to potentially enroll in directly.
Quick question. Hey everyone, Maggie Smith from University of Maryland Medical System. How does this align with the savings policy? Because I know just kind of transitioning to the PACES grouper, there's a lot more episodes, and like you said, it's not one-to-one. So how is that kind of going to be laid out moving forward?
Yeah, so the transition from Prometheus to PACES, it actually has no impact on the savings policy. So because of that overall, that high alignment, again, we're seeing the same sort of level of savings within each of the groupers. The decision or the savings decision isn't impacted. So yeah, essentially, if you're on or you're an at-risk entity right now based off of your performance in year 1 and year 2, that would continue forward. It's not like a clean slate or anything like that, just because we're using a new grouper.
Okay, I think we do have concerns about that just because it's under a different methodology, and just kind of the lack of clarity of how those NPIs will be connected as they shift around those entities. So kind of wanting to think through what that looks like moving forward, if we could talk more about that.
Yeah, and I think you bring up a good point. We're happy to sort of talk specifics. The NPI composition is certainly, I guess, a little bit independent of the grouper decision. Obviously, we know that participants have decided to, maybe they first approach it as a giant multi-specialty group, and then they've maybe made changes to create, different entities that are singular specialty focused and things like that. We do have certain policies related to essentially what is the definition of a new entity, succession entities, and things like that, and how the savings policy carries through over there. But certainly, again, essentially the composite of your MPIs year over year is something that is looked at. Again, that's a little bit independent of the grouper decision.
And Jessica,
Okay, that's cool.
Go ahead, Maggie. I'm sorry.
Oh no, that's okay. Go ahead.
No, I was just gonna kind of piggyback on what Maggie said, because I've actually heard a lot of concerns around the saving policy and some of the uncertainty around a couple issues. I think a lot of the practices are a little worried that there might be a delay in data because of the change problem. And then that delay will mean that if you had this savings, let's say you were like hypothetically a urology practice that started in year 2 because we didn't have urology till year 2, and you had this savings, then if the data gets a little delayed this year, you can't really make adjustments or have problems, and then we're going to they might be theoretically ineligible, and then they can't do anything about it, and then we're going to a totally new grouper altogether. I've had a lot of questions and concerns around that, so I don't know how much flexibility we can ask CMMI for, or what we can do, but it does seem, with all the changes between changing from Prometheus to PACES and other things that have occurred, it might be reasonable to come up with some kind of way to let people continue in the program.
I'd say, William or Krista, do you want to take that?
Yeah, I was just gonna, I think certainly we tried to build this program very flexibly and generously, and that, the sort of ability to redefine EQIP entities and how you define a continuing entity and so on is sort of a challenge we created by doing that. I think maybe what we could plan to do is maybe in the next one of these meetings, we could recap where we are with the savings policy and how we're planning to implement that. because I'm not sure we've really gone over that with this in this forum, and we'll take that coming back and just consider if there's anything else we think that we need to allow for, given the change in grouper. The one other thing I would say with that, that I want to make sure we don't get lost in this, that, you know, there's a bunch of complexity and mapping and pain in this transition.
Oh, wow.
I think we want to emphasize, you know, ultimately we think we're going to be in a much better place. So we appreciate people sticking with us while we transition the grouper. As you know, it's not ideal to have to do it, but also wanted to point out that ultimately we think we'll be in a much stronger place with an open source grouper that is independent on a large national payer, and also gives us a lot more control over when we run the data and how we run the data and so on. So want to also emphasize that big picture benefit to the grouper change.
Well, I will say this, we were lucky or brilliant that we were making the change away from change when we were, because if we weren't and we were stuck with these guys with what's happened, that would be really bad. Do we have an idea of how long the delay is going to be on the data? I know
So
that
we are
we've been,
still, yeah, we're still optimistic that we'll be able to release final PY2 results at the very end of June, so next month. We don't think that there'll be a delay. Again, we're always a little cautiously optimistic. But essentially, because the delay caused us to jump directly to doing full year, all 4 quarters of reconciliation, rather than, you know, we missed that Q3, which was right when the data breach and everything had happened. But we really hope that, I mean, it might be like days before the enrollment portal opens, but before the enrollment portal opens, that we're giving entities their final results for PY2.
and when do you think we'll have Q1 results for year 3?
I think that would be the release after the June release. So what is that, September? I think, if I'm getting those right.
But you see what I'm saying? I mean, if you had an entity that came in year 2, they had the savings, they're not going to have any, they don't really have their final numbers, particularly if they're close. And then we're not going to give them their first quarter numbers until there's 1 quarter left to fix it. So that's all. It just,
Yeah.
you know, and I'm really worried if the change stuff does delay it at all, it could essentially mean that you don't get a chance to fix things until it's way too late. That's all. So I do think what Will suggested, going through the successor, the savings policy, and putting some time at a future meeting is a really good idea, Will. So that sounds like a good way to handle it.
Yeah, and I think, you know, we all completely understand in general, regardless of change or anything else, obviously claims-based performance data has a natural lag to it. And, you know, we're hoping that lag would be reduced by a couple months by us being able to run the PACES episodes directly, rather than relying on, you know, Change or Optum Health to run it right now. But certainly hear you. And yeah, that's definitely something that we've heard time and time again about the lag. So okay, well, I think I touched a little bit on this, but I think really the big deliverable after this conversation is mapping out exactly what it means, so you all can see how these enrollment groups pan out, and have some conversations about if you are trying to make decisions about participating in a treatment episode directly versus enrolling in that larger enrollment group that encompasses those parent and child episodes. So we hope to have that to you guys on mid-June. We will have sort of the final definitions of all of our episodes finished out this month, and then we'll be able to turn it around to you all. As always, we are open to conversations to discuss specifics with you all, especially once you get the transition guide in your hand and have some internal conversations. If you'd like to discuss, please reach out to the EQIP inbox and we're happy to talk. Okay, so that kind of closes out the grouper definitions for right now. The next big item that we're going to talk about, and the last item on the agenda, is quality metrics and the rebasing decision that's been made. So just as a reminder, we're going to background of the composite quality score adjustments. So as you all are aware, the shared savings rates, there is a component that is subject to the composite quality score adjustment. As a reminder, quality adjustment is a requirement in order for us to keep EQIP's status as an advanced alternative payment model. And we had made the decision early on that the 3 quality metrics that were being used are the same 3 quality metrics independent of the clinical episode category, independent of a practitioner's specialty. But essentially, for every episode that is in EQIP, each HSCRC assesses whether all three of the quality metrics were performed, again, by any practitioner, essentially within the year prior to the end of the episode. How the quality composite score comes into play is really twofold. So that final number or score determines the amount of the 5% earn back adjustment that entities get before receiving their final shared savings incentive. And it does play into continued eligibility. So if during a performance year, the EQIP entity is below the 20th percentile benchmark in the state for any one of the quality measures, that EQIP entity is placed on probation for the next performance year, and essentially 2 consecutive program years on probation does make them ineligible to continue participation in the following. So as a reminder, here are the 3 quality metrics that are being used. We use the CMS guidelines when it comes to the methodology and the codes that go into the numerator and denominators for each of these metrics. So let's talk about this rebasing. So the decision was made because obviously a big part of AAPM, but also we want to ensure that this isn't singularly focused on just cost, and there is an incentive for providers to look to ensure that quality is improving while also looking at other efficiencies. So again, the decision has been made to update the quality performance thresholds and no longer use the calendar year of 2019 when it comes to these percentile breakdowns. So this is effective starting next performance year in PY4 or calendar year 2025. The threshold will be based off of calendar year 2022 data. Also note, there were, I think, 3 non-billable tracking codes that were sort of added on to the methodology on top of CMS's definition of these quality metrics. In this analysis, we really showed that there was none to marginal difference in using the tracking codes. So for that decision, they've been decided to be removed so we don't have a customized definition, and we really are following exactly the definitions at the CMS level for each one of these. And again, these benchmarks include, you're being compared to the tracking codes that have been excluded as well. As to be expected, when we're updating, 3 years or adding 3 years to the performance, when the performance is being evaluated, the benchmarks did show a significant improvement compared to 2019. The next couple slides will show exactly what those numbers are, but overall, when we're looking at that 20th percentile, or essentially that probation cutoff, in both advanced care planning and BMI, the percentiles doubled. And then for the medication reconciliation, the 20th percentile increased by 1.5 times. So you guys can look at these numbers, at your own time, but essentially, again, highlighting the differences you'll see here of the breakdown in these different performance rate percentiles in using the calendar year 2019 data and the calendar year 2022 data. I think the big question people have is like, okay, well, what does that mean? How does that impact me now? So I think one of the big things is that we want to emphasize here is there is no retrospective change in the benchmark, meaning that if you are currently participating in PY3, you're being benchmarked off of the calendar 2019 threshold, since that's what was implemented at the time of enrollment. So let's walk through exactly what this means for each of the years. So for PY2 and for PY3, the composite quality score adjustment, or that 5% earn back, is going to be based off of the 2019 thresholds for quality. When it comes to PY4 probation, so our existing PY3 entities, are you not going to be on probation for PY4? Again, we're still using calendar year 19 as the thresholds because that was the performance year. That was the baseline that was set during the performance year. Now, really where this comes to play is in PY5 and PY4 final reconciliation. So when we're looking at PY4 final data, the composite quality score, the 5% earn back, is going to use the updated calendar year 2022 quality thresholds. Again, that's because it started in PY4, it's the full year PY4, and your final result or quality is based off of the PY4 thresholds. And the probation period would only be impacted by these new quality thresholds for PY5. So if you think about it again, when you're participating in PY4, you would know if you're in probation for PY5 based off of how the quality metrics, how you performed against the quality metrics in the calendar year 2022 time period. A lot of numbers there. But I think the big thing also we want to emphasize here is that we assess the quality at the time of enrollment. So for some of these time periods, like when you're using Prometheus, we have 6 months worth of data. We believe that when we're in PACES, we'll have a couple more months worth of quality data. But essentially, you will know prior to the start of the performance year where your quality is and how it compares to thresholds. So this is a change implemented starting next year. Again, it really does not impact or does not retrospectively affect PY3 participants, but those that are choosing to participate in PY4, which I hope most of everyone does, it does affect you guys moving forward. Questions, concerns?
There is a question in the chat, Jessica.
Oh.
Going back to the previous slide, will data downloads from EQIP different based on whether entities enroll in the enrollment group or single episodes under PACES? And actually, that's going back several slides. That was before we start this section.
Sorry,
and Jennifer, I will send the slides out to the group. We were making changes to it literally up until 10 minutes before we started, so they'll go out after this meeting, and they'll also be posted.
Would the data downloads from EQIP differ based on whether entities enroll in the enrollment group or single episodes? So I'm thinking that question is related to the DEX downloads from EQIP. So we would still have the same sort of episode linking file as well as the claims file associated with it. So I don't think it would differ. You would just see the attribution either at the treatment level or at the treatment episode versus the enrollment group. I think that was the question. And Victoria, let me know if that was not.
So are you saying that the templates will be the same as they are currently?
Yeah, I mean, we do anticipate some changes given that there are like specific Prometheus terminology that's in some of the, that's in the DEX downloads right now, at least in the episode linking file. So there will be some changes. It won't be exact, but there will not be a difference between the DEX files in a treatment group versus the DEX files in a enrollment group.
Got it. Thank you so much.
Yeah. But yeah, there will be, and there also will be some changes in the dashboards as well that you're seeing again, because some of it is just like the Prometheus logic or Prometheus terminology that's in stuff. But we're trying to keep most of the structure, if we can use it under PACES, hopefully the same moving forward.
All right, and Ashley asked what will be used in place of tracking codes for the quality measures.
So it's not really in place of, so they're simply being dropped. Let me go back to it. Each of the different quality measures have specific CPT codes that are, that do count as being completed, or if they're ineligible, things like that. Some of them impact the denominator, some of them impact the numerator of the evaluation. But we're just following the exact definition for these metrics from CMS rather than adding some codes or making sort of a customized definition.
Jessica, do you think it'd be smart to maybe do a separate meeting or an educational little short thing with Kim on the 3 quality measures in the codes, particularly with the change?
Yeah. I mean, we certainly can fold that into either the next meeting or a separate meeting.
Or we could do it separately if a lot of folks
Yeah.
don't need it, but I do think that it might be prudent, we could do something short or whatever. We could talk about that offline.
Yeah, we can.
We seem to get quite a few questions on these issues.
And I will note, I didn't think I put it in the quality slides, but one of the things we did see is that essentially every entity that was at risk, meaning that their baseline data compared to the quality thresholds in that same year in 2019, all of them well exceeded that 20th percentile cutoff when it came to their actual performance data. So ironically, we don't have any entities that were actually kicked out or even at risk for being kicked out for quality at this time. Cindy, I see your question. And are there any planned enhancements to the EQIP dashboards to allow more drill downs? I certainly think we are open to hearing suggestions. As we mentioned, there are going to be updates in general to the canned reports because we have to, just naturally given the grouper change. So if there are specifics of that you're looking for, we're certainly open to hearing it and see if it's something that can be pulled in. You can feel free to either email me directly or the EQIP inbox, and I'd love to hear any specific requests. As I mentioned, I don't think our plan is to upheave the entire dashboards or set of reports, but like I said, we're certainly open to conversation. Okay, don't think I'm seeing anything else in the chat. So that was the main topics for today. I will want to point out just a couple upcoming meetings and things like that. We haven't sent out the Zoom link yet, but we will shortly. We will have a meeting in June that's just focused as an enrollment webinar. So we'll walk through exactly what you will see when you log into EQIP, what selections that you need to make. We'll talk through again how that enrollment decision when it comes to treatment episode versus enrollment group, what does that look like in EQIP, and how do I ensure I'm looking at the right number when it comes to eligibility, as well as walk through the additional practice transformation section or application that's been rolled into the enrollment portal. So that will be on June 14th. Again, we'll send that out. It, of course, will be recorded and posted on everyone's websites if you're not able to make it in person. We also, knowing that behavioral health is a new specialty that we're adding, we will be hosting a behavioral health specific group or meeting. We're looking at that date. We're committed to June, but haven't nailed down the date. Of course, we'll send that out as well. And then finally, for those that are interested in the EQIP primary care program, that meeting or the next meeting that one was just recently updated to not conflict with the Juneteenth holiday, and that will be on June 26th. So again, if you don't have any of these invites, please email us. We will get you on the distribution lists, and as some of the meetings are scheduled, we'll of course send those out as well.
So, and just on the behavioral health episode, I believe we ended up with a episode around depression, and what was the other one? Anxiety?
Yes.
Yeah, those were the two. So kind of those are the triggering things. And I see, I think you answered the question about the baseline year, but then Dr. Lowentritt said we don't need to discuss it with the whole group, but how are we doing on the PACES update on prostatectomy?
Yeah, two good questions. And I'll just, for Victoria's question, I'll confirm for the quality metrics or using the calendar 2022, it's only for the quality metrics. It is not rebasing the baseline cost for any of the other ones. I think that's conversation for future years. We mentioned that the focus this year was just transitioning the grouper. So yes, solely looking at the quality updating, the quality basing for that. And then for the prostatectomy, we should have some final numbers within a week or so. And happy to follow up with Dr. Lowentritt directly, but essentially there were some updates to the actual definition in PACES, and we believe that will have the numbers closer together. Once we have that definition, we'll be able to run that and actually look at the differences between the two. And I think we'll definitely reach out to you directly and probably send something out to the group once we have a summary of the updated definition.
Maybe Dr. Lowentritt is part of a very large urology EQIP entity. Maybe that entity
Meet with them.
could have a special meeting with us. We can set that up, Jessica.
Absolutely.
Okay.
And then there was a question about, will there be a neurology neurosurgery work group? I think we are very open to essentially, if there's any large practice, if there's any specialty that wants to have a more focused overview of the specific episodes, overview of PACES or anything like that, we are very happy to schedule something. Gina and I can look at calendars. As mentioned, you want it to be just at your practice, you want it to be to a large specialty group. We can sort of tweak slides and just focus on the areas of interest. But certainly reach out to us and we're happy to schedule something.
Yeah, and Dr. Parikh, one of the things we've done, and I've done it more than once, we've reached out to all the national specialties. I've written letters to them. I've asked them for input, and a lot of them have worked very closely with us. So I would love to have a discussion around neurology, particularly. The other thing we can do right now, if you'd like, just shoot us your email. or shoot us an email, and we'll send you the PACE list that is somewhat baked and the PACE list that is not baked, and we can look at it and see if there's anything logical to work off of for future years. But we're very, very excited about either having work groups on existing bundles or work groups to develop new bundles that would make sense. So that's music to our ears.
Great.
All right.
Hey, Gene, I was going to weigh in on one more topic from the HSCRC perspective. This program, unfortunately, we have to think a long way ahead, right? This has been the PACE's year, and Jessica and the implementation team are still deeply involved, and you guys are still deeply involved in that. But from a program development point of view, we are already beginning to think about what I guess is program year 5, anyway, 2026, calendar year 2026. We've identified preliminarily the 2 big areas we think we're going to look at for 26. One will be the quality measures. We have a lot broader number of episodes than we did when we set up the quality measures. That whole field has moved forward, so I think that's one area we'll be looking at. The second is the baseline period. To the earlier question, we've had requests of some of the episodes where they would really prefer a post-pandemic baseline instead of 19, but obviously we also don't want to pull the rug out of people who have been in the program the whole time and relying on that 19 baseline. But it is getting a bit old, so we do need to think about what our policy is. And in the original program design, we said we would look at how to adjust the baseline. No decisions have been made. Don't want to make it very clear. I'm not proposing to change the baseline across the board on people. But those are the 2 topics, quality measures and baseline, that right now we think will be the big changes when we're implementing the enrollment for 26 this time next year. So if people in the back of their minds could begin to think about where they think we should go on those issues, we'll launch that discussion with this group, probably in the early fall, because it does take us quite a long time to implement changes. So want to prime people to be thinking about, those 2 topics and what you'd like to see happen. Again, 26, 25 is staying as Jessica's described it. That's a 26 discussion, but just wanted to tee that up.
So I just, in response to that, Will, one comment, I think looking at the quality measures makes sense, but we're planning on staying with the claims-based quality measures, right?
That's certainly the going in assumption. I know that's been important to folks. So, and we have not, we haven't had a big pressure from CMS or anything to change that, but we do want to make sure we're doing a good job with those and the measures make sense.
Yeah, and I think that's very reasonable and is logical, but the claims base is a big deal. It's so much easier for the practitioners from a lot of other models where there's just a lot of extra unnecessary work. And the other nice thing about claims is if someone is billing something, that means that it happened, because they're very nervous about getting in trouble. So I think it's really measuring something that really happened. So that would be my one comment. My second comment would be, while those are 2 very big things to work on for 26, which I know might sound like a far away, but it'll be here before you know it. We'll probably start talking about it next fall. I just hope we also save bandwidth to keep adding new bundles, because this year, because of the crosswalk to PACEs, I think Jessica and we were hamstrung a little bit, honestly. We were lucky we got the primary care program. It looks like, knock on wood, possibly is going to happen. And we definitely got the behavioral health one done, which was great. But I feel like there's potential for more bundles, and that takes time. So if we're taking a lot of time to work on those other 2 measures, we just need to make sure that we plan and have time to continue to expand the program to more opportunity and more potential savings for the state.
Yep. No, I think that, and some of the reasoning for changing to PACEs was it gives us an awful bigger, broader base to work from. So, so we would view continuing draft episodes as being true every year. Those are really the topics when you think about sort of overall program concept. And certainly if somebody else has some sort of fairly fundamental thing they think we should be thinking about, now is the time to let us know that, because
one other fundamental thing I would like to have a discussion about, and maybe you can think about this and get back, is I would also like to see if we could somehow do this in some level, maybe for some specialties with Medicaid. So I understand the specialists generally are paid so badly in Medicaid that there's really no way to have a value-based care program just because Medicaid doesn't pay specialists well. But I do think there might be certain opportunities where it might make some sense, maybe with pediatrics and others. I do know that CMMI has been pushing the state for 5 or 6 years to add Medicaid to MDPCP, and the state hasn't been able to achieve that. This might, there might, like I said, I think we should at least have a discussion about that and see if that's a possibility. In my mind, pediatrics and behavioral health are the two places where that could be a pretty cool opportunity. So that would be something I would ask to be added. I don't know if anybody else has anything else they'd like to throw on the table to think about for 26. And then I see we have one more question. Jessica, I don't know if you want to address that. Or did we get that one now?
Sorry, trying to find how to unmute myself. I apologize. Let me look at it right now. Confused on the NQF. So looking at the CMS definition, my read of the definition is that the metric has some of the tracking codes that satisfy the metric, but we said that they're eliminated. So I guess I'll, correct me if I'm wrong, HSCRC team, but what we are saying is that we are following the CMS definition. So if some of those codes are in the CMS definition, they of course count. There were some tracking codes that were added on and were not part of the CMS definition. And essentially we're saying we're not maintaining any add-on codes, but using the definition as it reads for CMS.
Yep, I would agree. That's if their tracking codes are in the NQF definition, we use them.
Well, that's very, very helpful. All right, anybody else have anything? Man, I felt like in a very short time, we did a lot of heavy stuff. A lot of heavy lifting. Anything else? Anything else for the good of the order, Will, Krista, Jessica? All right, your last chance. All right, what a great way to start our Memorial Day weekend, guys. Have a good weekend. I'll try to get the recording up before I leave the office today.
Thank you.
Thanks, everybody. Have a good weekend.
Thanks.